Well, kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit. I'd like to welcome you tonight to this webinar on eliminating liver disease, where we're going to be talking about hepatitis C, B, and non-alcoholic fatty liver disease. We've got a great lineup of speakers, and we've also got Helen Liley and Peter O, who are going to relate it back to the health pathways. So we'll be linking everything through to the health pathways tonight. This has been organised by the Northern Regional Alliance Group. So I'm just going to invite Dr. Rawiri Jansen, who's the Chief Medical Officer for the Maori Health Authority, to give a karakia and start the talk tonight. He'll be talking about overview of hepatitis C and equity issues. Kia ora, Rawiri.
Yeah, kia ora, Bruce. Ngā mihi hoki kia tātou. Tātou e tauawhi nei I tēnei kaupapa I tēnei pō. Nō reira, ko taku karikia e pēnei ana. Ko nā ahuatanga ki runga, nā ahuatanga ki raro. Ko nā ahuatanga ki waho, ko nā ahuatanga ki roto. Ko nā ahuatanga o te ao te kitia, kia tau ki rungi a tātou. Te manaakitanga o nā mātua tūpuna hei arahi a tātou. Tū turu whakamaua kia tūna haume hui tai ki e. And yeah, thanks, Bruce. Really great that you're hosting us. This is a really interesting topic. I'm excited, I've got to say. I'm really excited. I've got some colleagues online, you know, who I want to do the big shout out. We've got Ed Gane, like, you know, absolute legend in terms of hepatology, and I've got some other mates like Helen Liley who can talk us through some of the pathway stuff. So for me, I want to kind of locate it. I've got some slides, I'm going to talk to them in a minute, but we've got this really remarkable opportunity. I'm rapt that, you know, in our practicing lifetime, we come to some really interesting places, and something that was really complex and intractably difficult and, you know, a cause for liver cancer deaths is now, tonight, we're talking about something which is really manageable. It's not just manageable in terms of better outcomes for patients, but it's really manageable in terms of fitting into primary care and general practice workloads. And, you know, so all of the actions that can take place to eliminate hepatitis C, bang, we're right here, we're right now, and we can get this done. So I'm going to share my screen and I'll just talk through briefly. And I've got acknowledgements to give to Ed Gane, because he wanted me to have the kind of the right start to our webinar tonight. So he's helped prepare some slides for me to talk to, and this one's mine. And this one is about the, I'm really interested in the idea that we're going to stick it to Hep C, right? And we've got this national campaign, and we're telling a story about sorting this out. We can really make a difference. So tonight, this is one of the messages that we've got to bring. As always, Bruce, you'll know me, I'm going to be interested in equity. And so I want to make sure that we, you know, front foot the fact that this is going to make a really good contribution in terms of equity. So let's just think about it. Here we are in 2022. We're going to move through sort of reaching out to the population who's at risk. We're going to talk about what's required in testing, and then what's required in terms of treatment. Big question is about how are we doing in terms of this, you know, big audacious goal of eliminating Hep C. And if you've got the little country in the right-hand side down in that corner, we've got some prevalence, and we've got to work through that. So the ambitious impact goals from the World Health Organization have some really incredible changes in terms of what's happening with Hep C worldwide. And for us, this is going to really make a difference in terms of liver-related deaths from hepatitis C. And, you know, for me, that's a really key driver in it. And right now, today, we've got 11 countries around the world who are on track. And on that list of countries on the left, there you see New Zealand's not on it. Sorry about it. So we've got some work to do. And one of the things that we're talking about tonight is really lifting our game, bringing our focus and our attention to this really important work and getting us back on track to do this really remarkable thing of eliminating Hep C. So to help us get back on track, the Ministry of Health on their website, you're going to go and grab a copy of this, you're going to download it. It's going to really inform you and keep you up to date and really straightened up about what we need to do Aotearoa New Zealand. So we've got to get busy in terms of awareness and understanding. So thanks to everybody who's joined tonight. You know, thousands of you, and kia ora and welcome, because this is a really important kaupapa. We can get really engaged in terms of the prevention and harm reduction, and one of the photos that I had there for you to look at is in terms of the needle exchange. You know, as primary care health practitioners, we come in and we're going to get really busy in terms of the testing and the screening, and from that we're going to get really busy in terms of treating it as well. And so in the phase that we're in right now, you would have noticed already the Hep C campaign. We've got programs of activity, and we've got Hep C, you know, managers up and down the country now and regionally who are getting busy in terms of engaging in harm reduction strategies and supporting community organisations. We've done a whole lot of work in terms of the data, and underway now the surveillance system registry is really critical, obviously, to the work that we're doing. And you'll see that we've got, you know, lots of people involved in prison populations, and you can get your fingerprint test done in a pharmacy and outreach vans, and so we're moving into all of that. And you know, for primary care, we know that this is a much better way of reaching the population who's most at risk, and it's probably worth thinking about who's at risk of Hep C, because, you know, I'm getting old now, but I was a bit of a mischief bugger when I was young. And there are lots of people who will have a story about being a bit mischief when they were younger. And actually, if we can reach out to people to just think about what those risk factors are from decades ago, that's one of the things, that's one of the conversations that will help in primary care for us to get busy. This is Ed stuff, so this is far too complicated for me. What I'm most interested in is that the fingerprint test is really easy, and then we can get down to the treatment. And I was talking with a cardiologist from who came out from UK today, and we're doing some work, but he said, oh, so you're getting busy on the Hep C, and what are you treating with? And Maravit is what we're treating with, and we can really get that done. So I might stop sharing there, because I think the big point is that we've got thousands of people together tonight to talk about Hep C, elimination of it. I'm really excited by the work that we can all do in terms of making real difference for patients. And, you know, we've got these really brilliant colleagues who are going to talk us through some of the detail of all of that. So, Bruce, good work. Here we are. Let's make a difference.
Yeah, well, great start, Rawiri, and I think thank you very much for that. Nice way to introduce us. A nice way to introduce Ed Gane, because you don't have to go far overseas and talk to a gastroenterologist and they know who Ed Gane is. He's sort of world famous, and really has been responsible for most of the treatments, I think. And I always think these new antiviral drugs are a bit like the it's a bit like the penicillin days, really. It's sort of 1941 all over again, 1940-41. So I'd like to introduce Professor Ed Gane, New Zealand Liver Transplant Unit, and Professor of Medicine, who's going to talk about eliminating hepatitis C. Over to you, Ed.
Thanks, Bruce. Kia ora, thanks, Rawiri, for a fabulous introduction. I'll just share my screen. So I was sitting here 4 years ago at the last Goodfellow symposium we had on hepatitis C, sitting in a room with Richard Davies from the Calder Centre, talking about these wonderful drugs we have. That's the easy part. Now we have to find the patients and engage with them and treat them. And this is really what I'm going to spend the next few minutes talking about. Really, Rawiri pointed out the WHO goals to eliminate hepatitis C by 2030. To do so, we have to be treating about 2,200 people per year based on our current estimates of the numbers of people living with Hep C in New Zealand. And you can see we were doing pretty well at the beginning. Mavorite was introduced back here in beginning of 2019, when we were treating around 500-600 people a month. But gee, have the numbers fallen off? And you can see that over the last year, we've treated just over 500 people. And this drop off in treatment numbers was before COVID. It's got worse with COVID, but the numbers dropped off because, of course, we ran out of people to treat, as we haven't increased testing at the same time as we increased treatment. Rawiri has shown this slide. This is the key to how we get back on track, how we're going to get up to 2,500 people treated and cured a year. Well, there are three major things we need to do. That's simplified treatment, and I'll talk to you briefly about how we can't get any simpler than what we are now, how we improve linkage to care, and perhaps later on, we're going to look at wider testing programs in our general population. Now, if we talk about simplifying treatment, as I said, we have the simplest and most effective treatment in the world funded here in New Zealand. And this is this combination of two drugs called Mavorite. And there's really no restriction. People can be retreated again if they get reinfected, which is great. And this just summarizes the big studies for different types or strains of hepatitis C, shown down the bottom. For both people without cirrhosis and people with cirrhosis, you're achieving cure rates of over 99%. Now, this is just unprecedented in medicine, that you can really pretty much eliminate the infection in anyone who takes the full course of treatment. And the full course of treatment is 3 tablets once a day for 8 weeks. And really, that person will largely be cured. And I've shown this slide a few years ago because this has continued to improve. With simplification of the treatments from the bad old days of interferon up until what we're looking at now. This is Vicuropac was only for genotype 1, but more complicated. You had to give lots of tablets. To Mavorite, which is once a day, you can see that from the time we allowed general practitioners to start treatment in late 2016, this really has been taken over by primary care. And this is really replicated around the world. Treatment of hepatitis C is now a community-based treatment that's moved out of the hospital. And I would guess that in 2022, we're now treating less than 10% of people living with Hep C who get treated are treated actually within the hospital. And these are only the complicated cases. We reported on the first 3,000 of people who were treated, and this was of the older, more difficult Vicuropac. And about 40% were treated by general practitioners. In those days, 60% by patients. And we followed them all up, and we showed that the cure rate was exactly the same. So there's no advantage in that somebody tracking down to the local hospital to get treated. They'll have the same outcomes by being treated by their GPs. In fact, more people will be treated if you actually allow them to be treated in the community than having to go to hospital. Now, this is just some estimates that looking at the numbers of people whom I think can be safely treated by their general practitioner. Now, when we started in 2016, this was the really difficult to use Vicuropac oral treatment. We could really only treat a small number of people. They had to be genotype 1, they had to be not treated before, and they couldn't have cirrhosis. And that was about a third of the patients. And that when we moved to Mavorite, suddenly everyone could be treated with one-size-fits-all Mavorite, and that increased the numbers who'd be treated in primary care to around 90%. The other thing that had happened was a lot of the cirrhotics and a lot of the people who had previously failed other treatments were picked up and treated in the early days of Mavorite therapy. I would forecast that by next year, the vast majority of people can be treated either by their general practitioner or in the community setting. And I would strongly advocate that compensated cirrhotics should now be treated in the community. They need to be followed up afterwards, but the only people who need to go to hospital are the very few patients we have who have liver failure or who have failed previous treatments such as Vicaripac, and these numbers are very, very small. How do you simplify the testing pathway? Well, first of all, symptoms and signs and liver function tests are pretty much useless. Up to 40% of people with hepatitis C will have completely normal liver function tests. So these are not useful. You need to look about risk factors if you're doing targeted testing, which we're doing now, and then do the antibody test. Now, the antibody test, remember, reflects either previous or current hepatitis C infection. Even people who are cured will remain antibody positive. They're performed at every community lab in the country, and Rawiri's hinted on the movement towards point of care testing. These are like the RAT tests, and they are now available for hepatitis C. It's called the SD Bioline. And this is a very simple RAT test. It's a finger prick, and you get a result in under 10 minutes, which tells you that that person's antibody positive. And anyone can go onto the Stick It to Hep C website and find a local centre where they can go and get a pinprick point of care test for an immediate result. But of course, that just tells us that they may have hepatitis C. They have to have the confirmatory RNA assay, and that is currently done at the reference lab. So you have to have a blood test, which is sent to the reference labs. I should tell you that there's a point of care test for RNA, and that's available, for example, in the CAD centres around Auckland. It's a special machine called the Gen Expert machine. We're hoping that more of those will be rolled out around the motu over the next few years to enable the high-risk populations to have a single one test. We don't do genotype anymore. Cirrhosis, we need to know. You don't need to worry if the person's under the age of 30 or has been injecting for less than 10 years. I've never seen a Hep C cirrhotic in this country under the age of 35, because it takes decades to get cirrhosis. And the reason we want to know if someone has cirrhosis is because they need lifelong follow-up. We don't do liver biopsies anymore. We do a simple blood test called the APRI score. And an APRI score means you request a platelet count and an AST level, and then you put it into this online calculator, which tells you the APRI. If the APRI is less than 1, then the person definitely does not have cirrhosis. If the APRI is more than 1, it's about a 50% chance they'll have cirrhosis, and they need to be referred for a FibroScan. But the vast majority of your patients, about 90% of them, will have an APRI less than 1, and you can get on and treat straight away. Lab tests are designing an APRI request form, but that's not yet available for you to use for your electronic requests. We want to know if somebody has Hep B co-infection, if they are born before neonatal vaccination, or if they've been born overseas. And that's simply because of a small but definite risk of reactivation of the Hep B, but it's only if they are born over the age of 30 and aren't immune. HIV co-infection, one of the successes of our needle exchange program is that we have virtually no HIV transmission in our injecting drug use population. So we only test for HIV and hepatitis C patients if they are MSM. There are some drug interactions, but these are actually really rare with Mavorite. It's much easier to use than the other older treatments. And very few drugs may be stopped or just switched while you're on the 8 weeks of Mavorite. Never adjust the Mavorite dose. Always give it at 3 tablets a day. Never reduce the dose or split it. And if you want to be check whether the drugs may interact with Mavorite, and Helen will talk to this, there's a simple online checker which is available in the Health Pathway, and she'll direct you to that. Simplifying monitoring, no on-treatment blood tests are required unless people have cirrhosis. We do a simple post-treatment test for cure at 4 weeks post-treatment, not 12 weeks anymore, and only 4 weeks. And in fact, if the person's 100% compliant, you could argue that that's probably unnecessary. And there's no further follow-up if someone is cured, unless they're cirrhotic, in which case they need ultrasound. This is the pathway on the Health Pathway, the algorithm, and Helen will direct you to how you get to that. So to finish, how do we eliminate hepatitis C? How do you eliminate hepatitis C? It's simple to stop new infections, and we do that by enhancing our harm reduction and treatment in people who inject drugs. But for you to know, you are the ones who will reach our targets in reducing mortality, and we do that by increasing testing and treatment in the general population, those people who haven't been at risk for 30, 40 years. And for that, you'll hear about what's going to come in the future, which may involve a wider testing program and certainly a registry. And a registry will help us prevent duplicate testing and ensure linkage to care. And you'll hear a lot more over the next few years about innovative approaches to wider community access to point of care testing and wider access to treatment. So thank you.
Thank you, Ed. I'd just like to introduce Dr. Helen Liley, who's going to just walk us through the health pathways.
Hi, everybody. I'm just going to start with a hepatitis C pathway. This is Auckland's pathway, but it is going to form the basis for a national pathway. So this is a pathway that's coming to you soon. You already have your own versions of this, but there's going to be a national version. So just a quick mention that to find any pathway, the best thing is to put it in the search function. You can find Hep C by looking under medical, then gastro, then liver conditions, and then finally chronic Hep C. But putting any thing in this search box here is always the quickest way to find things on health pathways. This is the chronic Hep C health pathway. It actually looks quite short on the page, which is always nice to see. So basically the assessment section walks you through which test is right for your patient. It tells you what to do with the result of the test you've done for your patient. And then it tells you how to assess your patient in terms of their management. And then we have the management section, which tells you who not to treat in primary care, how to treat who you are treating, and then some discussion points for all patients. So just looking in a little bit more detail, if your pathway looks like this when you open it, you've got a plus in the top right-hand corner. It means that your right-hand margin is closed. So if you press on that plus, it'll open the margin and you'll be able to see the key link there. And that's where you'll find the diagram that Ed showed earlier. So here it is again with just a few extra little bits on it, but that's basically the whole pathway on there, the details on the actual pathway, but that's just gives you direction of where you're going. So the point of care testing link is in that bullet there on assessment 1.3. And if you click on that drop down, that's where you'll find a link to the hepatitis C, Stick It Hep C website. And then if you select your region at the bottom, it'll tell you where your patients can go. Just dropping down to the liver assessment, because part of that is the APRI score, as Ed mentioned. And in that drop box down there on assessment number 7, is where you'll find the link to the APRI score. And this is what it looks like. Remembering that you will have at the moment to ask your lab in Auckland anyway for an AST specifically, because it's not part of the normal liver function tests. But plug your numbers in there and it'll give you your APRI score. Moving down to the management section, there is in Auckland and in other parts of the country some funding for general practitioner treatment of Hep C. And if you click on that drop box there, you'll find the link to the POAC website, which tells you how to make your claims in Auckland. But basically, it's just the same way as you make any POAC claim via your practice management system. This is the treatment drop box. I'm just going to open it for you now. And there's the drop box in which you'll find the Liverpool Hep C checker. Ed showed another screenshot of this, but this is what it looked like when you're actually doing your tests. So you'll put your Mavorite in this column here. You'll put whatever medication you want to know about the interactions in this one. And then it'll show the interactions on the right-hand side. So I've put a torvastatin in on purpose. It says do not co-administer. You'd probably stop it, to be honest, just for the sake of 8 weeks. But if it is a drug that you don't want to stop, you can look for alternatives in the bottom right there. Then we have treatment number 4 tells you actually how to do the prescribing. And one of the most important things is to make sure your prescription goes to a pharmacy that supplies Mavorite. And that link there will take you to the Mavorite website, which has the pharmacy locator on it there. So if you click on there, you'll get a map of the whole country. I stuck Auckland in there, and you can see how many locations are around Auckland, but I could have put anywhere in New Zealand around there, and there are absolutely loads of pharmacies, so your patients won't be struggling to find somewhere. And that's all I want to say about the chronic hepatitis C pathway. Thank you.
Next speaker is Dr. Akhilesh Swaminathan, who's a gastroenterology trainee at Auckland Liver Unit, completing a PhD in new biomarkers. So he's going to talk to us about fatty liver and new referral pathways for this.
Thank you very much once again for the invitation to speak today. After talking about the success of hepatitis C, it's time to move on to what's next on our horizon, which is fatty liver disease. So on today's update, what I'll be aiming to do is to give you a bit of a background into metabolic associated fatty liver disease, or MAFLD for short, explain why it's important, and also how we can manage these patients. So let me just make sure that the screen sharing is working there. And so non-alcoholic fatty liver disease, which you've probably all heard about, is the original definition of this disorder. It was first proposed back in the 1980s, and it's essentially described a heterogeneous group of disorders where we saw liver dysfunction in the absence of any other alternative diagnosis for liver disease. And the problem with this definition is that it trivializes what is in fact a multi-systems disorder and puts a particular focus on descriptions of alcohol consumption, which has its own associated stigma. Fundamentally, what we want to actually describe with this condition is the impact of metabolic dysfunction and its consequences on the liver. And with this in mind, there's been a shift in the last 2 to 3 years to have this more inclusive definition of MAFLD, which better encapsulates these risk factors. So how big is this problem? Well, MAFLD is likely to affect over a quarter of the world's population, and there's a growing prevalence as well. We see MAFLD in over half patients who are overweight or obese, and in over 2/3 of those with type 2 diabetes. And despite this high prevalence, less than 5% of patients with MAFLD are actually aware of their illness. And this lack of awareness is important, given the significant burden of this condition to patients, healthcare providers, and society in general. How big is this problem in New Zealand, you might ask? Unfortunately, we have very little data on MAFLD in New Zealand. But if we consider the major risk factors for this condition, which are obesity and diabetes, we can estimate the likely impact of MAFLD in the coming years. We know that more than 1/3 of Kiwis are obese, and this proportion is steadily increasing, with rates of childhood obesity that are also on the rise. And we also know that the incidence of type 2 diabetes is also rising. And these conditions are even more relevant for our Māori and Pacific Island communities, who have significantly higher rates of obesity and diabetes than Europeans. Furthermore, Māori and Pacific Islanders with diabetes are more likely to have poor long-term outcomes. So you can clearly see that the burden of the MAFLD epidemic is fast approaching us. So how might we encounter a patient with MAFLD in our day-to-day practice? The majority of patients with this condition are completely asymptomatic, and they might have metabolic risk factors with mild derangement of their liver biochemistry. Patients with advanced MAFLD can present with completely normal liver biochemistry, so the degree of transaminitis is not at all a good reflection of the liver disease as a whole. Another common scenario where we encounter MAFLD is when we see terms such as fatty liver, hepatic steatosis, or steatosis reported incidentally in radiology reports. We have to remember that this is a pretty broad definition and can define other liver disorders such as alcoholic liver disease as well. And so we have to take it back to the metabolic risk factors and put this in the context of our patient. An additional note is that hepatic steatosis is really only a diagnosis made on a liver biopsy when we see more than 5% of cells being affected. Ultrasounding of the liver is a fairly inaccurate and crude measure for this, and you need more than 20% of your liver to become steatotic before we start to see any changes. So it's not a very sensitive test for this at all. So how should we screen our patients with MAFLD? Well, there's no consensus and much debate about this ongoing. A practical approach may be for us to consider a more thorough assessment in patients with either hepatic steatosis that we found incidentally on imaging, those with metabolic risk factors with mild liver dysfunction, and in those with type 2 diabetes. And the steps that we should take after we identify these individuals is to do simple blood tests, such as the ones listed here, and specifically in Auckland, in terms of the liver function test, to also include an AST, which I'll get to in a moment. And we also need to assess for modifiable risk factors, such as alcohol intake and a patient's cardiovascular risk profile. These assessments are pretty important because we need to risk stratify these patients with MAFLD. And as you can see on this diagram, patients with MAFLD have a significant extrahepatic burden, and actually the biggest contributor to the excess morbidity and mortality associated with this disease is not related to the liver. And we know that only a small proportion of individuals with MAFLD will actually develop liver-related complications, and this usually occurs many years after the initial diagnosis. So it's important that we accurately stratify a person's level of risk. And the only consistent predictor for long-term risk in MAFLD is the degree of liver fibrosis. How do we do this in practical terms? The first step is to identify those at risk for MAFLD. And the next step is to calculate non-invasive liver fibrosis scores, such as the FIB4 or the Fibrosis-4 index, which is shown here. Now, this can be calculated using clinical parameters as well as biochemical tests that we can routinely order. And the FIB4 not only predicts the degree of liver fibrosis, but also helps prognosticate the long-term risk in MAFLD. The accuracy of this score does, however, vary with age, which is why we have different thresholds or cutoffs that are stratified by age. In the Auckland region, we've started to use FIB4 thresholds of 1.3 for those aged 60 or below, and 2 for those above 60 years old. Now, these thresholds have a high negative predictive value, meaning that if an individual has a FIB4 score below these thresholds, there's a 90% chance that they won't have significant liver fibrosis. However, conversely, these thresholds have a low positive predictive value, meaning that a significant proportion of people who have scores above these thresholds won't actually have advanced liver fibrosis. So therefore, we need to pair this test with a second one, and for that, we use transient elastography or FibroScan to help improve our diagnostic accuracy. A key point to remember in all of this, though, is that even once a patient enters a pathway like this shouldn't be a one-off assessment, as MAFLD will progress over time, and so it's important that we reassess our patients every 2 to 5 years. Once we've risk stratified our patient, what do we do next? Well, unfortunately, we don't have any effective pharmacological treatments for MAFLD, and really our only approach is like an ambulance at the bottom of the cliff. We can ask our cardiologist to help manage cardiovascular complications, and we as a gastroenterologist can help manage liver-related issues. However, the biggest benefits are from managing the underlying metabolic risk factors well. And as you can see, no single healthcare practitioner can achieve good long-term outcomes in this MAFLD epidemic. And really, what we need to be striving for is a coordinated, team-based approach, and GPs are central to this. And whilst we wait for new drugs to show promise in MAFLD, the best intervention we have for this condition is anything that can contribute towards meaningful weight loss. As you can see on the schematic here, a 7 to 10% loss of total body weight can result in almost complete resolution of steatosis and steatohepatitis, which is a key driver of the long-term risk of fibrosis and a complicated MAFLD course. And if we break weight loss down in a piecemeal fashion, we can suggest dietary modifications and structured weight loss programs for our patients. Unfortunately, though, although all of these interventions can result in meaningful weight loss for a short period of time, it's unlikely to be sustained in the majority. Bariatric surgery is a highly effective treatment in MAFLD and reduces steatohepatitis and also stabilizes liver fibrosis. It also reduces the long-term risk of hepatocellular carcinoma. We should be considering this in all of our patients with a BMI above 35, provided that they don't have liver cirrhosis. Unfortunately, given our current resource constraints in New Zealand, we are limited in what we can offer here. In terms of other modifiable lifestyle interventions, recent meta-analyses suggest that any level of alcohol consumption can potentially accelerate the course of MAFLD, and abstinence is probably best. And when it comes to managing metabolic risk factors, GPs play a vital role in this domain. A few key points to mention here are that for patients with MAFLD, metformin, SGLT2 inhibitors such as empagliflozin, and insulin have not shown any benefit in improving steatohepatitis, whereas medications like pioglitazone and the newer GLP-1 agonists result in significant improvements in liver histology, and this persists for many years after therapy. Once again, we need to consider a patient's cardiovascular risk profile and commence the appropriate prevention strategies based on this risk. We don't have any MAFLD-specific guidelines for this. And also, we want to slow the progression of this disease. And so we need to consider withdrawal of medications that can potentially aggravate MAFLD. And examples of such medications are listed here. So in summary, MAFLD is a global health problem that is likely to have a significant impact on the New Zealand health system. We need to consider this condition in those with metabolic risk factors and in those who have been identified to have hepatic steatosis. Given the high prevalence of MAFLD, it's very important and absolutely crucial that we risk stratify our patients using non-invasive tools such as the FIB-4 score. As we know, the degree of liver fibrosis is what actually determines long-term outcomes in MAFLD. And although we have limited effective treatments for this condition, we have to consider a multifactorial approach to manage this epidemic moving forwards. Thank you.
Okay, thank you very much. That was really great. Helen, would you like to now just talk about the Auckland Health Pathways on this topic?
This is the Auckland MAFLD pathway. Also, Northland has the same pathway, very similar pathway. So I've got even less time to tell you about this. So here we go. Again, put fatty liver in the search box, or MAFLD or NAFLD, any of those things will find you the pathway. It's the top one there. This is the assessment section. Oh, whoops a daisy. And again, if your screen is opened up like this, press on the plus and you will reveal the flow chart. There we go. So Akhilesh showed a version of this, but that's the one that's on the health pathway. And basically it summarizes the whole management there. So this is the assessment section of the pathway. It tells you who to assess and how to assess. And most pertinently, it gives you the FIB-4 calculator there. I'll show you that in a second. Management section, the first part of that, numbers 1 to 3, is telling you who to refer and what to do when you've decided on the risk level. And the rest of the management is basically, as Akhilesh said, managing the risk factors. And we've linked you off to all the useful pathways there. So diabetes, weight loss, bariatric, green prescription, smoking cessation, blood pressure, hyperlipidemia, all those are linked off for you. So just a reminder that you'll need to ask for the AST, again, a reminder in Auckland, and there's the FIB-4 score highlighted at assessment number 3. That's what it looks like when you go there, and you just fill it in like all these calculators and it gives you the result. Whipping down to the management section, management number 3 there shows you each of the risk types. When you press the drop down, it just defines the risk type for you. And then briefly, it just tells you what to do. Moderate or high risk, you refer. Mild risk, you repeat your FibroScan. Or if you haven't got to FibroScan, you repeat repeat your other assessment. And if it's minimal risk, you recalculate the FIB-4 score every 2 years. Going down to number 4, as I said before, that's just telling how manage all those risk factors. Importantly, down at the bottom there's a link to a website that tells you all the hepatotoxic medications, and you want your patient to be avoiding those. And there's the website that links you to. And that's all I've got time to say. Anything about that pathway? Thank you very much.
So thank you, Helen. Just one quick question. Do you ask the lab for the FIB score or the AFP, whatever it was? There's just some confusion there.
No, you ask for the AST because you don't get it when you ask for liver function. So you ask for liver function and platelets and the AST. You have to specifically say AST or you won't get it from the Auckland lab, but you need it to plug into that FIB-4 calculator.
Okay, then we put it into the calculator and get a score. Doesn't come back from the lab.
No.
Okay, I wonder if that might be a step that might speed things up if the lab could convert it and give us a FIB score.
Yeah, a bit like the APRI. Yeah, it would be good.
It is something that we're, I'm sorry to just chime in, it is something that we're working with the lab providers in Auckland to see if we can get it calculated automatically.
Great, well, thank you very much, you two. Back to Ed Gane, who's going to talk about abnormal liver function tests. Over to you, and Peter O will make some comments from the pathways.
Yeah, okay, thanks, Bruce. This can be pretty short. This is a great pathway what Peter and his colleagues have put together. And it really looks at how you evaluate how you evaluate abnormal liver function tests. So just to remind you, liver dysfunction, if you look for it, is incredibly frequent. It's usually it's usually transient. It's due to drugs someone started, or an intercurrent infection, such as a viral infection. And almost all cases can be managed in primary care. I'd also point out that chronic liver disease is common. About 5% of our population have one of the chronic liver diseases you're hearing about tonight, in particular hepatitis B, alcohol, and NASH. And up to 10% of those have established cirrhosis. So these people, you do have to worry about their liver function tests. And the number of tests done are really very high. Last week alone, around 21,000 liver function test requests were processed in Metro Auckland. So it's probably about 3 to 4 times that for the country. So large numbers are passing through. And really what you need to know, you can get from the pathway, is when to order tests, how to interpret the abnormalities, what other investigations are required, when you, for example, do other blood tests, diagnostic tests, when you order an ultrasound, and finally, when do you refer to secondary care. Just a couple of, I won't go through everything, just a couple of points to make, is that transient minimal elevations of liver function tests are usually pretty benign, and they don't generally need further investigation or referral. And in those I include alk phos and GGT levels of less than 1.5 for less than 3 months, AST or ALT or both of less than 1.5 times upper limit normal for less than 3 months, or even the bilirubin, which is less than twice upper limit normal for less than 3 months. But the corollary is everything longer than 3 months or above these thresholds does justify further evaluation. And if you get all the cholestatic enzymes elevated at once, that's usually a trigger for further investigation, in particular for biliary obstruction. A single liver dysfunction parameter, again, is usually a benign cause. And you need to remember that all the parameters we look at, alk phos, AST, GGT in particular, can be induced and may not reflect liver injury. GGT is induced rather than caused by injured liver. So alcohol, drugs, or steatosis make the liver produce more GGT. Alk phos can be produced by many different organs outside the liver. So if you get an isolated elevated alk phos, you have to think of diseases other than the liver. And similarly, AST, as we know, can be caused by skeletal muscle, heart muscle injury, even brain injury or red cell hemolysis. So an elevated AST, think that it may not be liver related. And an elevated bilirubin level of more than twice upper normal should always be split. And by split, I mean into direct, indirect, or conjugated, unconjugated. Because unconjugated hyperbilirubinemia is found in about 7 to 8% of the population, and that's a benign cause called Gilbert syndrome. And that doesn't justify further investigation. The two patterns we talk about are hepatocellular or cholestatic. Hepatocellular or hepatitis is where we look at the elevated AST and ALT, and in severe cases with an elevated bilirubin. A cholestasis or biliary obstruction is where we get an elevated alk phos and GGT plus or minus bilirubin. But be aware that in many cases, the patterns will be mixed because you can get a mixture of hepatocellular inflammation and biliary obstruction. And certainly in chronic hepatitis, it's quite common to get very mild elevation of alk phos and GGT, as well as your ALT and AST. And in acute biliary obstruction, you can also get an increase in AST and ALT because the acute biliary obstruction causes backflow, pressure, infection inside the liver, which hurts the hepatocytes. So nothing is always definitely hepatocellular or definitely cholestatic. It can be a mixed pattern. What about hepatitis or hepatocellular injury, which we're very concerned if it is severe? How do you separate acute from chronic? That's pretty simple. Acute hepatitis means it's short-lived. It's been elevated for less than 1 to 2 months. You usually, if you have an AST or ALT more than 10 times upper limit normal, that almost always is an acute hepatitis rather than chronic hepatitis, where the levels are much lower. And if somebody has symptoms, then they're much more likely to have acute hepatitis. And the usual symptoms you'll see in any acute hepatitis is malaise and anorexia and nausea, and in severe cases, jaundice. Chronic hepatitis, by definition, is 6 months or more. But of course, when you diagnose it, that patient may have had elevated liver function tests for many months without knowing. So you need to follow these patients to see whether they have chronic liver disease. I think the one thing you need to know in primary care is that the most common cause of abnormal liver function tests is a drug-related cholestasis or drug-related hepatocellular injury. So a careful history is absolutely integral to working out the cause. Alcohol use is by far the most common cause of liver dysfunction in our population, but also many prescribed medications, which are outlined in the pathway. I won't go through here. Over-the-counter medications, chronic paracetamol ingestion, even at 4-6 grams a day, can cause a hepatitis. Of course, there are many other causes, as you know, such as supplements, CAMs, and traditional Chinese, Pacifica, and Māori medications. Certainly, kawa tea can cause quite severe liver dysfunction in some people. It's always important to consider when did you start the drug as to whether that could be the cause. Dose-related toxicity usually happens within days to 1 or 2 weeks, whilst idiosyncratic hypersensitivity can take weeks or months to develop. But you need to look at when did the person start that medication. And remember that drug-induced liver injury can be all types of patterns. It can be cholestatic, hepatocellular, or mixed. Now, what are the red flags? The red flags which you really need to look further and consider discussing with secondary care and probably referral to secondary care, I'll just go through briefly. You've got the non-urgent referrals, and these are patients with suspected cirrhosis, any cause. This isn't because you can't manage cirrhosis in primary care, but currently for further follow-up and surveillance for hepatocellular carcinoma, currently patients need to be under secondary care. If you look at the confirmed diagnosis of hepatitis B, hepatitis C, or MAPL, and you meet criteria for secondary care review, then obviously that person should be referred. And these criteria are outlined in the specific health pathways for these conditions. There are many other types of liver disease which are uncommon or even rare and are difficult to manage. And I think with these, the ones lined out here, it probably is necessary for a specialist assessment and certainly initiation of treatment, although long-term treatment can often be managed in primary care. And of course, if you don't know the diagnosis, that is also a reason to consider referral for further more sophisticated testing. Urgent referrals are clear if you think the person may have primary or secondary liver cancer, or if the person may have acute or chronic liver decompensation, or what we call liver impairment. And liver impairment, it can be subtle, but it's usually becomes very obvious. There are no specific symptoms of decompensation. People may report dark urine, weight gain from their ascites or leg swelling. They may have changes of their sleeping. They may just lose impotence in men as they become decompensated. The physical signs are all of those which are associated with advanced cirrhosis. And the laboratory evidence and the LFTs are usually an elevated direct bilirubin prothrombin ratio and a reduced albumin. A low platelet count is very important because that reflects, of course, what we call portal hypertension, which means advanced cirrhosis. And we'll come to later when you should consider ultrasound, but ultrasound can be very, very useful for determining whether somebody has liver impairment and needs to be under secondary care. I'll just finish by pointing out that the pathway I'll hand over to Peter to outline in a moment. But there is a national resource which was just updated and released last week, and this is the BPAC liver function test and primary care document, which is online. This is quite a large document. I oversaw the writing of that, and I must say it is in keeping, it's very consistent with the Northern Health Pathway for liver function test abnormalities. But this is a big document. It's a 20-page document. So it's a good resource to look at and read and download. And I think I'll finish there and hand over to Peter to go through the pathway.
So I'm here to show you the new abnormal LFT pathway created in partnership with Ed and other local experts. And you can find this pathway best by simply searching for abnormal LFTs, but you can also navigate through the menu headings as well. The pathway follows Ed's presentation to assist with outlining the causes of LFT disturbance, criteria for further investigations, and referral to specialists. Our assessment section details possible causes for abnormal LFTs, including traditional and complementary medications that may be contributing, as Ed mentioned. And the differentials for hepatocellular and cholestatic patterns are also formatted into a table. The management section details indications for specialist referral at the top and specific advice for each LFT pattern within their respective drop-down boxes. Using transaminases as an example, the drop-down box expands on interpretation, the frequency of retesting, as well as the thresholds for further investigation. Liver ultrasounds, the criteria for this based on enzyme levels is also summarized here, and Barnett will expand on this in the next talk. Our pathway discusses the management of medications, alcohol, and weight, which is central to managing liver disease. And this section in the pathway links to specific pathways for weight and alcohol intervention. If the patient is found to have viral hepatitis or fatty liver, then further management is detailed in the pathways Helen discussed earlier. Otherwise, that concludes my very quick overview for the abnormal LFT pathway. A huge thank you to our subject matter experts who made this possible. And back to you, Bruce.
Okay, Peter, thank you very much. Our next speaker is Dr. Barnett Bond. He's currently the reviews the referrals for liver scans in the public hospital radiology service. Over to you, Barnett.
Thanks, Bruce. All right, when to request an ultrasound of the liver and when to not request an ultrasound of the liver. Let's talk for a moment about your radiology department. Radiology departments have supply issues and demand issues. Here's a graph of the growth of demand for ultrasound year on year. That's our hospitals in Auckland, but yours will look very similar. Note that 2022 is there in the middle, and the years after 2022, the predicted years, look depressingly similar to the years prior to 2022. And here's what the supply looks like. This is all sonographers in New Zealand, including the ones that do echoes, fetal anatomy, and livers. A couple of questions for you. What is 399 minus 350? Next question, how many years were there between 2013 and 2022? Are you optimistic? In 2020, we had COVID. You can see that although it made the annual growth rate in demand went negative, there was still a growth rate. So two challenges. First challenge, resources to do the ultrasounds that you request, and the second challenge is the utility of the ultrasound you requested, given the clinical scenario that you described. So the solution to challenge number one is your school-age children. Tell them they can earn between 87,000 and 105,000 per annum 1 year after graduating, and that they'll be paid to train to be a sonographer and that the job is fun. The solution to challenge number two is down to you, the referring GP. And you've heard tonight the answer to challenge number two is contained here in the pathways. And as you've heard, the easiest way to find something in the pathways is to type something into that little box, into the search box. And you can see that you can type all of those requests in and you will get the answers that you're looking for. But tonight I'm just going to talk about the one in the middle at the top, because it seems that this is probably the most frequent reason that referrals come to our ultrasound department. And I want you to think hard about abnormal liver function tests. And as Peter Orr has said, please refer to the pathways before you do, because if we let's take a couple of examples. If you look at the MAFL pathway,
This is taken directly from the MAFL pathway. Ultrasound is not part of the MAFL diagnostic process. Only request abdominal ultrasound if criteria are met and there's no obvious cause for elevated LFTs, i.e. all investigations are normal, the patient is not obese, and drugs and alcohol have been excluded as causes. We get large numbers of referrals for ultrasound liver in patients who've got slightly elevated liver function tests when these things have not been done. If you look at the next example, this is taken straight out of the hepatitis C pathway. Chronic hepatitis C is slowly progressive. Around 20 to 30% with chronic hepatitis C infection will develop cirrhosis. I won't read the rest of it except for the last sentence. Cirrhosis is diagnosed with elastography and not with ultrasound. Okay, so I'm not sure what's happened there. Oh, there it is. So this is a cut and paste from the pathway list of liver function test conditions that will be accepted for liver ultrasound in most of your regions. And you can see that they're all about elevations in various liver enzymes for various lengths of time. How reliably are these elevated LFTs linked to serious liver disease? Well, as Ed Gane has said, markedly elevated liver levels are strongly linked, mildly elevated levels less so, and the pathways obviously spells out which, much more detail about that. A word about the UNLN, which appears through our pathways. It stands for the upper limit of normal. As our pathology colleagues constantly remind us, the ranges they publish on the lab results are not normal ranges, they are laboratory reference ranges. A laboratory reference range is defined as the set of values that 95% of the normal population falls within. That's 95% prediction interval. That means that 5% of the normal population will have values outside the laboratory reference range. Thus, the reason that you see that we want liver function tests repeated at intervals, and we want certain other interventions done. So I've highlighted in red a condition that attaches to the gamma GT, but there are published papers in the last few years suggesting that we should also attach that condition to the other transaminases. So the summary of this is that all of the above will be accepted for ultrasound because they are the current rules. However, these acceptance criteria are based on papers which were published before the sharp spike upwards in Western world obesity. Nearly all patients with a BMI greater than 35 have MAFLD. Many over 30 do too, and if they're obese for long enough, they'll all get it. You do not need an ultrasound to know this. The treatment for early stage MAFLD is the same as the treatment for obesity. You do not need an ultrasound to know that either. A small number of patients with MAFLD will go on to develop steatosis, and a few will get steatohepatitis. Make sure your patients know this. Many obese patients have liver function tests persistently slightly above the upper limit of the laboratory reference range. But there are papers published showing that small amounts of weight loss can often result in the LFTs returning into the normal range. Certainly, tighter diabetic control and abstinence from alcohol will return them to the normal range. So if a trial of weight loss or abstinence from alcohol or tighter control of diabetes, or in many of your patients, a combination of the three, result in a reduction in ALT, then your patient doesn't need a liver ultrasound at this time. So there's two take-home messages, both labeled number one. First, talk to your teenage children. Sonography is a noble career with a bright future and it's well paid. Bribery is okay. It worked for Qatar and it can work for you. The second take-home message is read the pathways and remember that there's an overworked radiologist or sonographer who has to read your referral. Try to fill their lives with joy and not despair. Make no mistake, we will do the ultrasounds that you ask us to do, but tonight you have heard that there's a great deal of primary care workup that you should do first. Bruce, back to you.
Okay, thank you, Barnett. And our final speaker tonight is Ed Gane, talking about primary care prescribing for hepatitis B. Back to you, Ed.
Thanks. And I promise you this will be the last time I talk to you. Now you can see that. Yep. So this is something which I am really quite excited about. I've told you how well general practitioners have been in rolling out treatment for hepatitis C. And really, the only way we'll achieve elimination for hepatitis C is to move treatment entirely into the community. I do believe we're moving that way for hepatitis B as well. And I think this is going to be a very, very important point needed to try and reduce the enormous disease burden of hepatitis B in this country, which far outweighs any of the other liver diseases. We all know how good infant vaccination is. And of course, prevention is better than cure. And there's no doubt that infant vaccination will eventually eliminate hepatitis B across the world. In fact, it will eradicate it. It is so successful. And in many parts of the world, except for sub-Saharan Africa, vaccination rates are well over 99%. But it will take 90 years. It's going to take 90 years to eradicate hepatitis B. In the interim, 80 million people are going to die from liver cancer if we just rely on vaccination alone. And that's because there are about 280 million adults who are living with lifelong hepatitis B acquired as infants. And they won't benefit from vaccination. And about a third of them will die from liver cancer. I should point out a very sobering statistic for you. 30 years after the introduction of universal vaccination in New Zealand, and we were the second country in the world to roll it out, we still have increasing numbers of patients presenting with liver cancer from hepatitis B. And just remember, the mean survival after diagnosis of liver cancer is still less than 6 months. And of course, this reflects an aging population, but also a large number of people moving here from countries where hepatitis B is endemic. So how are we going to help eliminate hepatitis B? There's a very similar slides to hepatitis C, but we have to find patients, we have to reduce the stigma associated with hepatitis B, and we need to provide unrestricted access to simple, effective, and affordable drugs. And we have these. We have oral drugs. The ones we have in this country, entecavir and tenofovir, fully funded, unrestricted, lifelong funding for patients who need it. But very few people are currently being treated. We know there are around just under 100,000 people living with hepatitis B. These are adults in this country. Around 2/3, 60% have been diagnosed, but the numbers actually started on treatment are pathetically low. Only 6,000 patients currently are receiving pharmac-funded entecavir or tenofovir in this country. This is certainly far lower than we need to reduce what I show, that mortality of liver cancer. And the problem is, up until recently, the special authority criteria said that to justify treatment, you have to have an ALT more than twice upper limit of normal. And here it's these two phases called the chronic hepatitis phases, E positive, E negative. And so you had to have both a high DNA and a high ALT. Now, we now know, over the last 4 to 5 years, we know that that is not the right approach. And a very large study in Taiwan showed that if you use the same criteria pharmac used in the special authority, that you had to have an ALT more than twice upper than normal, 2/3 of patients who eventually developed liver cancer in this long-term follow-up would never have met criteria for treatment. So 2/3 of patients with preventable liver cancer were never offered treatment. We now know that suppressing hepatitis B with entecavir or tenofovir in patients with low or normal ALTs will prevent cirrhosis. In this beautiful study, they showed that if you matched patients and gave half of them placebo and half of them with treatment, but they had low ALTs, so they didn't meet the special authority criteria, that those patients who got the treatment had a reduction in cirrhosis of 2/3. More so, suppressing HBV with entecavir in patients with low or normal ALTs will prevent liver cancer. And in a similar study, this one in Taiwan showed that if you match patients who got treatment with a low ALT, you reduce the risk of liver cancer by 70% over long-term follow-up. So there's an argument, a strong argument, for treating patients based on DNA levels, not on ALT levels. And by doing so, you will be able to reduce the risk of cirrhosis and liver cancer. ALT is a very poor predictor for both of these complications. It's a virus. This is what we're learning. This is a viral infection. So we should be treating the virus. And Pharmac saw this, and about 3 years ago, they switched from our current branded treatments to generics. And that overnight reduced the cost of treatment by 90%. And that enabled Pharmac to remove the special authority criteria and allow people to be started on treatment and maintained on antiviral treatment in primary care. And this really has opened up the possibility for us to treat more people. These are very safe treatments, and to treat them in primary care. Now, this is a simple algorithm, and Helen's got this beautifully outlined in the pathways. But the most important thing is looking at if they're surface antigen positive, doing an HBV DNA. If their HBV DNA is more than 2,000, they should be considered for treatment. Everyone with an elevated ALT, even just above limit of normal, and even if they have a normal ALT and they're over the age of 30, who have any other risk factors for liver cancer, they should also be started on treatment. And treatment is long-term, once a day, entecavir or tenofovir. There are some other indications for treatment, and these are all for people with low HBV DNAs, but that's not for you to worry about. Those patients are all for secondary care. These are patients with renal impairment on chemotherapy, children, women in pregnancy, people with HIV or receiving PrEP. All of those will be managed in secondary care. The crimson square on the right, it's really the patients who should be treated now in primary care, and this is long-term treatment. This is like treating someone's cholesterol or someone's diabetes. You put them on long-term treatment to prevent liver cancer. What about stopping hepatitis B therapy? This is a very simple slide. There's only one indication for stopping treatment, and that's somebody who clears surface antigen. Not e antigen, clears surface antigen. So they become surface antigen negative, surface antibody positive. They are truly cured of their hepatitis C. You need to confirm that 3 months apart, but that is the only stopping criteria for treatment. Everyone else stays on lifelong treatment, which, as I've shown you, is very cheap and very effective in preventing cancer. Thank you. Helen, over to you. So every one of those hepatitis B related cancers would have been prevented by earlier treatment. And we're seeing around 100 cases a year. Still.
Thanks, Ed. I'm not going to show the whole of the hepatitis B pathway. I'm just going to show the treatment in primary care section, which is nestling at the bottom just above the request section. And it is a simple treatment, as Ed said, and it's a very small section. So the first part tells us who we shouldn't be treating in primary care. These are the exclusions that were on Ed's slide. And we've got some recommendations for who you should take advice about before you start treating in primary care. And then you carry out the treatment on the rest. As Ed said, very simple, entecavir or tenofovir, and you can help decide which one by doing the renal function or the pregnancy test. And then these two bullets here tell you which one to use for which type of people. And then Ed didn't touch on the follow-up monitoring, but it's all detailed on the pathway for you. Reasonably simple. After 3, 6 and 12 months, tells you what to do. And if they're on tenofovir, you also do these additional tests. It tells you how to manage abnormal results if you throw them up. And it also just gives you a reminder to arrange surveillance for liver cancer for the right set of people. If patients don't have access to specialist surveillance, they live too far away, they can't get there or whatever, it does give you an idea of how you can monitor them best yourself. And it also just gives you a bullet as to what to do if the patient stops treatment. As Ed said, just about everyone should continue on treatment for life. So if they stop treatment, you tell them to restart it again, check their liver function in case there's been a flare. And if you're not sure, you ask your local Ed Gane. Thank you very much.
Okay, thank you very much, Helen. That was fantastic. I was just going to say how much your colleagues appreciate the Auckland HealthPathways. They really have transformed the way we do business. And I was traveling with a GP colleague from Auckland the other day who was just raving about very excited about the HealthPathways. So we've got some questions there. Question there about measurement of ferritin fit in. if high ferritin abnormal, abnormal LFT, what would you do?
I'm not sure if that's for me or for Akhilesh, but I think high ferritin obviously can mean iron overload, but that's a very, very rare cause of high ferritin. Probably only 1 to 2% of people with ferritins over 500 are caused by hemochromatosis. It's far more likely to be related to NASH or alcohol ingestion. So I think you just need to take a good history.
Okay, so we've got that one done. What about pregnancy?
Pregnancy and hepatitis B, I guess. Pregnancy for and hepatitis C, I was just asked last week whether we should start introducing routine testing for hepatitis C in pregnancy, and I think we're moving towards that. For hepatitis B, we already have routine testing, and women who are hepatitis B positive, there's an algorithm the obstetric physicians and obstetricians use. It means doing an HBV DNA, and if it's high, they get a tenofovir in the 3rd trimester to prevent the baby from catching hepatitis B. But regardless of the hepatitis B DNA level, all babies should get a birth dose vaccination within the first 12 hours after birth, plus a single dose of hepatitis B immunoglobulin. But I think certainly our obstetric centres are very good at ensuring that occurs at birth.
Just a question there about the Hepatitis B Foundation. They monitor some of our patients. Should we be relying on them to say this person's eligible for antiviral treatment, or should we be, are they up with the play on that? I'm just not sure.
They certainly are. They have some very good medical directors at the foundation, and I work with them to update their algorithms. Are now doing regular HBV DNAs, and we meet with the foundation regularly, and they are going to start. They are currently referring people to secondary care to start treatment. But Susan Hay, their CEO, said she's going to start now writing letters to the primary care physician looking after that patient to say that this patient should start treatment. So that is going to happen certainly next year.
So we can rely on their
yes, oh yes, that's a perk.
And that's a question from Rebecca about hepatitis D. If having hepatitis D concurrently with Hep B is a reason for referral for specialist care, then that means that Hep D, which I've never heard of or never tested and don't recall seeing any health pathway, is a test we always need to consider in her Hep B workup.
Good. I took out my Hep D slides for interest of time, but it's a very good question. Delta in New Zealand is restricted to people from certain countries. And it's really west of the international date line. The further west you go, the higher the prevalence. In Samoa, around 20% of people with hepatitis B have hepatitis D co-infection. Kiribati, about 30–40%. If you go further west, it goes up to about 50%. It's only in those islands. There's no D or Delta in the Cook Islands, Tonga, Niue, New Zealand Māori, Asians or Europeans. So we should always test for Delta in people from Kiribati, from Samoa, or from Melanesia or Micronesia.
Question there from a GP in South Auckland. How do we get access to these finger pricking tests?
I think you're going to have to send me an email. Yeah. So we've got point of care testing around. We can work with you, especially if you've got a particular event or a day or a population you want to get busy with. So yeah, email me, rawiri.mckree@health.govt.nz.
Okay, and we've cleared all the questions, team. So I think it's time to close the show. Thank you very much for all being very punctual and keeping to time. There's some very good feedback coming in already about the seminar, so you really covered a lot of ground. And I think that probably one of the take-home messages is to go to those health pathways. So, and congratulations to those of you who have been fostering those. They're really becoming a fantastic quiver in our tools. So on behalf of NRA and Goodfellow Units, I'd like to thank you all and say good night.